we proceed with acute inflammation of this abdominal gland. Any inflammatory process is combined with edema in the tissue. Therefore, we are scanning an organ with increased amount of fluid, and this causes a reduced echogenicity. The borders are irregular and not very distinct. We can find an enlarged organ with hypoechoic areas according to the regions of the inflammation. Sometimes we will detect small sections when dealing with a focal inflammation, or like in the next case, nearly the whole organ is swollen and hypoechoic. So we see a swollen, enlarged organ over here with a quite hypoechoic parenchyma. The borders are not very distinct, so we have all the criteria for an acute inflammation of the pancreas. Enlarged organ, very irregular borders, and a hypogenicity of the parenchyma. So with color Doppler, we try to find vessels. There are only a few seen in the periphery of this organ, and we take the measurements, and over here we have got the head of the pancreas, which measures 4.7 centimeters, so it's really enlarged, and we can make the diagnosis of a swollen, enlarged pancreas, and we have the diagnosis of acute pancreatitis. But is the whole organ involved in this inflammation? We haven't seen the cauda pancreas at all, so we have to do the left lateral intercostal view, and we're looking for the spleen. Maybe here's the splenic vein, and this portion of the pancreas is seen here. It's the tail of the pancreas, also hypoechoic, swollen, with very irregular border, so the inflammation has taken place also to the tail of the pancreas. The entire pancreas is involved. In other cases, we only see a focal pancreatitis, so that there are only some regions where we see this hypoechoic changing of the parenchyma. We can see it over here. Also irregular borders are seen at the body of the pancreas. And in the loop, you have to take a close look on this area, hypoechoic, quite dark in comparison to the body and the tail. So a focal, inhomogeneous, hypoechoic parenchyma in the head of the pancreas. The inflammation has only taken place in the head of the pancreas. When the inflammatory process exceeds the organ, we see also free fluid in the neighborhood of the pancreas. So over here and here and here. But I have to say, in the case of an acute pancreatitis, the conditions for ultrasound sometimes are very bad. So I think you will not see quite often a really acute pancreatitis in an ultrasound examination. But when you have all these criteria, you are quite sure that an acute pancreatitis is present. In a severe necrotic pancreatitis, we may be able to detect necrosis. But as I have told you, it's not so easy to get any image of the pancreas. But when you see this image over here, we have got hypoechoic and hyperechoic areas. So this can be an abscess or a necrosis over here. But I think a patient with acute pancreatitis has to undergo a CT exam when you think about a very severe cause of this disease. The risk of a severe disease depends more on lab tests, on clinical findings, than on any image modality. So what are the reasons? What is the etiology of pancreatitis and what are the complications? Therefore, ultrasound is the right tool to search for the etiology. We can find gallstones or going for cysts and necrosis. We can also detect this. You have seen these images of acute pancreatitis, but in daily clinical practice, it's not so easy to get any picture of the pancreas when there is an acute inflammation. But ultrasound is a right tool when you are looking for the causes of an acute pancreatitis or for complications. You can perform this examination at the bedside of the patient, and one has not need to transport the patient to the CT. So we can search for gallstones. I think we have already discussed this and we are almost experts on this topic. The next topic is the chronic pancreatitis, and there we can use ultrasound as well. We see calcification in the pancreatic tissue, a dilated and irregular pancreatic duct, and in the most cases, an increased echogenicity of the parenchyma. Also, the complications can be seen by ultrasound examinations, the obstruction of biliary ducts, and the progression of inflammation and the development of pseudocysts. The sonographic findings are calcification in the parenchyma of the pancreas, over here, and a mixture of hyperechoic and hypoechoic areas beneath. Also here, calcification in a quite huge part of the pancreas. And seen over here, also calcification in the abdominal aorta, but calcification in the pancreatic tissue. So on the video clip, you can see these bright echoes, dozens of them, in the parenchyma of the pancreas. And we can also see this tubular structure over here, which shows no Doppler echoes, and you can identify the dilated pancreatic duct over here. So we have got two criteria: calcification in the parenchyma and dilated duct of the pancreas. Also in this video clip, once again, we want to be sure that there is no blood flow in this tubular structure, so we don't want to mix it up with an artery. I show it again. Calcification over here, dilated pancreatic duct. Here you can very easily see the tubular structure again. I stop the video over here, and you have this tubular structure which exceeds almost 5 to 6 millimeters in the case of a chronic pancreatitis. Do you know what this structure is? I'll make a snapshot. We see this great vessel with a pulse is abdominal aorta. This vessel is SMA. So this is splenic vein, and all of this is pancreas. These entire parts of the picture you see is pancreas and the dilated pancreatic duct in the near field. So to sum up, we can differentiate between the acute pancreatitis and the chronic one. In the case of acute pancreatitis, we see an enlarged organ with a reduced echogenicity and irregular borders. In the chronic disease, we see calcification of the parenchyma, an increased echogenicity, and a dilated duct of the pancreas. We go on with focal lesions in the pancreas. There are quite a lot of cystic lesions in the pancreas, like serous cystadenoma, mucinous cystadenoma, and even cystadenocarcinoma. And there are pseudocysts, which appears after necrosis and pancreatitis. So when we find a cyst in the pancreas, you're going to describe the localization, whether there are septal and nodally, but at all, it's not so easy to make a diagnosis only using a sonographic examination. So in this case, we see cystic lesions with multiple septa in the head of the pancreas. Now it depends on the age of the patient and the gender, which of the diagnosis is more likely. And in some cases, it's possible to wait and see what's happening. In other cases, we have to take a puncture or an operation. But this is very hot stuff, and I will only discuss the cases where it's easy to make a diagnosis. For instance, in the next case. It was a female patient who showed up in the hospital after the second episode of an acute pancreatitis. She's 5 years younger than I am, but I'm not telling you how old she is. She's between 20 and 36. So we see a tremendous cyst over here. She suffers from pains, and we will see on the next video clip. There's the aorta. We have seen pancreas and this tremendous huge cyst at the region of the tail of the pancreas. In the follow-up examinations, the cyst showed growth and the complaints of the young patient become even more intense. So something had to be done. You see these huge cysts, more than 15 centimeters in this area. Endoscopy has been performed. The cyst was punctured and the stent was placed. So the cyst collapsed in the next 4 weeks and the acute problem had been managed so far. So the final diagnosis was a pseudocyst after an acute pancreatitis. So endoscopy was performed, the cyst was punctured and the stent was placed. So the cyst collapsed in the next 4 weeks and the acute problem had been managed so far. Next we come to the focal lesions, the tumors of the pancreas. We have got benign and malignant ones. And as I can say at all, it's not easy with imaging modality to differentiate between benign and malignant. But what is the most important fact about a focal lesion in the pancreas is, when you find a hypoechoic lesion in the pancreas, we have to assume a malignant pancreatic tumor. So we have to fix the diagnosis in a very short time, because when the carcinoma exceeds the organ, the prognosis is fatal. So here we see a hypoechoic lesion in the head of the pancreas, which is an adenocarcinoma of the pancreas. The next case shows us a very great lesion in the tail of the pancreas. It exceeds 4 to 5 centimeters, and especially cancer of the chorda pancreatica is killing nearly all patients because the symptoms are various, there are no early findings, and the patient shows up in hospital with an advanced stage of cancer. Sometimes the tumor is hard to find, and we will not be able to improve the prognosis for this particular patient, but save a patient's life using ultrasound. Sometimes we are able to save someone's life. In this case, we see pancreas over here. You see the guiding structure, the splenic vein. And have you seen already what's wrong over here? In this area we see a hypoechoic lesion. It's less than 1 centimeter in the corpus and the body of the pancreas. And maybe we can save this patient's life. Because when we get the diagnosis of a pancreatic cancer, which is below 2 centimeters and there are no lymph nodes involved and no metastasis, we have got stage 1A and the best prognosis for this patient. So we have to look carefully for the pancreatic parenchyma. Maybe we can see a stone, maybe we can see an inflammation, but when we see a hypoechoic lesion, we have to think about pancreatic cancer. And maybe this patient can be saved. In my opinion, your examination skills make all the difference when it comes to scanning the pancreas.